Okay, hi. I'm going to ask Felicia for you to spotlight Sherman, me, and Robyn and Julie. I'm so grateful to everyone on the line and in community for all of your help getting my sound on. Welcome to session 1. My name is Leora, she, hers. I'm part of Region 9, Pacific Southwest MHTTC. And I have the honor of moderating our first panel of day 1, evidence-based and culturally defined practices with Robyn Douglas and Julie Kaplow and Sherman Lee. You may have seen that Carolyn was part of our original faculty and she's not able to make it today. So we want to thank Carolyn for her scholarship and her work. And we're also really excited to learn from these 3 colleagues in the field. The beautiful news is that, if we can actually just go back one more time, the beautiful news is that we're starting off our conversation on evidence-based and culturally defined practices right after an invitation for us to really grapple with who holds knowledge around how we grieve and who holds the space with how we support the mental health workforce understands how to support grievers and themselves. So this conversation between Julie and Robyn and Sherman is to really elevate and amplify some of the grappling that the field is holding on to, what we're learning, what we still don't know when it comes to evidence-based and culturally defined practices. And I just want to name that there were some folks in the chat box during Megan's piece that really shared that while there is the dominant culture's approach to grief, which is to silence, uncheck, unprocess, uncenter, decenter, these are all my actual words, I'm just kind of flowing right now. No, but the dominant culture's way of disenfranchising, that there are many, many, many cultures that deeply center grief and hold on to grief celebratory, with joy, and with deep awareness that part of grief is being a human. So we're holding both. What do we know in the field from evidence-based practices, and what do we hold from folks who are teaching up to the dominant culture? Where is the conversation between? Where's the conversation between? I'm gonna take a breath there. We can move forward. Thank you. So in terms of housekeeping items, really quickly, Heather went over this at the beginning, but if you're just joining us, I want to go through this again. If you have something that you'd like to share with everyone, our 700 folks on the line, that's respectful, contributory, and generative, you can click on the everyone drop down and you'll be able to share that. If you have something just for the panelists and the hosts, you can click down just to host and panelists. And if you've got questions, we'll have time for Q&A at the end of this conversation. If you've got questions for Julie and Robyn and Sherman, please do put those in the Q&A. Julie, Robyn, and Sherman have also sent us slides that they're going to be using in order to help them track what they want to share, and those are on our website. My colleagues will drop that site in the chat box, but I really encourage you, if accessibility permits, to do some deep listening and deep receiving, and then you know that you'll have the slides to help track the learning later. Closed captioning is on, and I think that's it for housekeeping because we just want to get right into the conversation. Okay, let's actually just meet our faculty. So I'm going to invite us. Here's how this session will flow. And because this is the first session, this is actually going to be the flow for all of our sessions. Each faculty member, faculty panelist, is invited to share out who they are, why they're in the grief work, and where they are with the grief work. What comes up for them when they hear the theme, where are we now, and where can we go with our practice? Each person will share. We're actually going to go alphabetically, Julie, Robyn, Sherman. And then we'll have time to be in question and in discourse with each other, and then some Q&A and close. So deep listening, conversation, Q&A, and close. And on that note, I'm going to invite Julie to start, then it'll go straight to Robyn, then to Sherman. You won't even have to wait for my cue. Each person, we invite you to speak for about 10 minutes. Let me know if you'd like to queue, and I'll put my finger up, and that can give a 1-minute a 1-minute time. And let's learn from each other. So Julie, let's start.
Thank you so much, Leora. And I have to say, it is very difficult to follow Megan Devine. I truly think of her as one of my teachers, and I've learned so much from reading her work. And so I really approach this entire field of, and I'll say childhood and adolescent grief, because that's what I'm primarily talking about today. But I really approach this as I am still a student of the field of grief, and I'm still learning, despite the fact that I have been doing this work for at least 2 decades. I still feel like I learn new information every day, both from people like Megan Devine and many of you on this call, but also from patients and the kids that we serve. So I want to just tell you first, before I move into the Trauma and Grief Center and what we do, kind of how I came to this work. And I came to this work both from a personal experience and also professional. So my mom was in her 20s when her father died. She was very, very close with her father, and it was an incredibly difficult time for her. I was just a baby at the time, and I remember her telling me that she would rock me to sleep while sobbing over the loss of her father. And I know this might sound weird to some of you, maybe not, but I really started to believe later on in life that I absorbed her grief, because I understood that kind of profound loss in a way that I really shouldn't have, based on my own personal history. But as time went on, my mom shared with me a lot of information about how and why that experience was so difficult. Besides the fact that she was incredibly close with her father, but she didn't have an opportunity to say goodbye. She didn't have an opportunity to say things that she wanted to say. And so I became really intrigued with this idea later on of how do you maintain that connection to the person who died and cultivate a good goodbye, even when that opportunity doesn't present itself. And that sort of led me professionally to want to do a deeper dive into childhood grief and how kids grieve. I had the opportunity as an undergrad to work with an amazing professor, Albert Kane at University of Michigan, who was doing a study of parentally bereaved children. And still to this day, I don't know why he allowed me to do this. But even as a freshman, I had the opportunity to interview bereaved children. So these were kids who had just lost a parent. And what I came away with from that experience was recognizing that some of the kids actually seemed, and I'm hesitant to use this word because of what we just heard, but they seemed resilient to me. They seemed that they were going to do their best to kind of make sense of the loss in their own way and find ways of coping with the loss almost naturally, that they didn't need that much external support. And then there were other kids where their environment made it very difficult for them. So things like all of the pictures of mom had been taken off the wall. No one talked about the death. There was no one there to really be present with their grief and bear witness to that pain. And so as I started to learn more about what those external and internal factors were that could either help or hinder children, that's when I really started to become interested in, how do we distinguish between those kids that really need our help immediately, those, for example, want to end their lives, versus those kids who are actually going to be okay, and the vast majority we know are going to be okay without that higher level of support. But really, one of the things that I'm going to talk about today is helping the field to move forward with making those decisions and really listening to what the kids need and meeting them where they are. So another aspect of who I am is what I do. And so I want to just tell you very briefly about the Trauma and Grief Center. We now have 2 trauma and grief centers, one housed at the Hackett Center for Mental Health in Houston, Texas, another housed at the Children's Hospital, New Orleans. And we have 4 different pillars within the Trauma and Grief Center. And the first is really to develop evidence-based assessments and interventions for youth, and again, these are the youth who actually need intervention. We're going to talk more about that. Ages 7 to 21 who've experienced traumas or losses. We also do training and professional education in trauma and bereavement-related topics and interventions. We also conduct research on children's needs and strengths in response to trauma and loss, as well as treatment effectiveness do need intervention. And then policy recommendations based upon trauma and bereavement informed best practices. So if we know what helps children in the aftermath of a trauma or a devastating loss, how do we ensure that all of us are equipped to provide that support and the different types of supports that are necessary? Next slide. So I want to tell you about a theory that I've had the opportunity to work on with two colleagues at UCLA, Bob Heinous and Chris Lane, for the last decade. And what we've been really working on and thinking about is, how does grief naturally manifest in children? And what are the primary bereavement-related challenges that kids are often grappling with? And the first is separation distress. So this is yearning and longing for the person who died. The second is existential or identity distress. This is feeling lost without the person, or how am I going to get through life without the person? And the third is circumstance-related distress. And this is being very preoccupied with the way the person died. And what's really important to note about each of these dimensions is that there are ways in which that challenge or that dimension can very the death where it really keeps kids stuck or puts them at greater risk for other mental health issues down the road, including suicide risk. So with regard to separation distress, I just want to give you a couple examples. I was working with a young girl whose mother died, and her mother was literally her best friend. And so she was obviously very distressed in the aftermath, which is what we would expect. And one of the things we found as we sort of progressed through treatment was that as she started to do more activities or behaviors that she used to do with her mother, things like making her mom's favorite apple pie, taking swims, really enjoyed doing with her, that's something they enjoyed doing together, the more she engaged in those activities, the more she felt connected to her mother in a healthy way. And so we would consider that a more helpful side of that separation distress. With existential or identity distress, we hear kids saying all the time, I don't know how I'm going to get through life without my dad. We also hear them saying things like, I really want to live the kind of life my dad would have wanted me to live, or I want things that would have made me. Again, that's the more helpful side of that dimension. And then circumstance-related distress, we actually see kids naturally gravitating toward wanting to change the circumstances that harmed their loved one to help other people. So for example, I was working with a boy whose father died in a tragic plane crash. And when I asked him, what do you want to be when you grow up? He said, I want to be an engineer so I can make planes that don't break anymore. We hear things like this all the time. Kids raising money for breast cancer because mom died of breast cancer. Or a child saying, I want to become an ER doctor so that I can save lives in the way that I wish they would have saved my parent or my brother. So I would venture to say that some of our most important inventions and even interventions in society come from some tragic losses, including seatbelts and fire exits and other things in our society. So as Megan Devine mentioned before, there are aspects of this where, we need to embrace the pain, but we also need to recognize that there are ways in which we can grow from these experiences and actually make things better for other people. Next slide. So I want to name this right away, that these kids look very happy. And I want to also acknowledge that there are other cartoons that we use at the same, different grief experience. I did not do those here, but I wanted to, as we've been talking about what have we learned and where are we moving in the field, what we've learned is that for those kids that do need intervention, and we're going to talk more about what that looks like later in the discussion, there are some common practice elements that seem to be helpful and effective in ameliorating their intense distress. And what we also talk to kids about is that it's okay to still express joy and be happy even though their caregiver died. It's also okay and perfectly normal to be incredibly sad. And so when we're talking about continuing bonds, these are the three sort of most common practice elements that we find in the interventions that are out there for kids. And I have to say there are very few that have been, tried and tested in terms of their effectiveness for children. But the few that are out there focus on continuing bonds. So this is one domain where we help kids to find ways of connecting, healthy ways of connecting to the person who died. And so that can look like through the help of a caregiver or another caring adult, looking at photos of the person who died, talking about the person who died, looking at videos, finding ways of memorializing them. And the most important thing that we're learning is that it's just important to bear witness. So again, going back to what Megan Devine said, those caregivers that are able to sit with their child and feel their pain and be present for their pain, those are the families that where we see the most improvement for children in terms of their own levels of distress. Legacy building. This is finding ways of living a life that either would have made the person proud or actually helping to recreate the child's identity in a way that feels like they're fulfilling something. And so what I mean by that is, when someone dies, we all feel like we have changed immensely. And this is very true for children and adolescents, especially because their identities are still changing and still being molded. And so one thought about this is, being able to help kids to recognize the things that they had in common with the person that were actually positive traits or behaviors. So for example, it can be something as simple as, my dad was such a kind person. He was always kind to strangers and always talked to them. That's something that I'm going to do. Or, finding ways of carrying on the legacy of the person. If they were an artist or someone who used to run marathons, then doing those things that, again, help them to feel more connected, but are living their legacy in some way. And those are the ways in which we're able to, again, help children who are experiencing high levels of distress. And then meaning making. Children, this is a very difficult task unless they have already made sense of the death in some way. And what I mean by that is often kids are shielded from the details of how the person died, and they're often left very confused. And so before we can help kids to make meaning of their loss, we often have to help them understand how the person died. This can involve some very difficult and pointed questions, either for the caregiver, the physician, whoever it is, but really trying to help them understand how this happened. And from that point forward, as kids get older and as kids move through development, helping them to brainstorm about ways that they can make meaning of the loss, again, by transforming the circumstances of the death into something that either can help them or others to not have to suffer in the same way. And again, kids are perfectly capable of doing this. This is something that we've learned over time. Next slide. So I just want to mention briefly here that what we've also learned and are continuing to learn is that trauma and grief are two very different things. And sometimes the way we talk about this, even with kids, is that when you think about trauma and you think about how that feels in your body, especially if you think back to a time when you were so petrified that you didn't know whether you were going to have to freeze in place or run and hide, that's sometimes what it feels like to have PTSD. But when you think about grief, often the feeling that comes to mind is that profound sadness. Everything kind of slows down, feels very heavy, and that can feel very different in the body. And if you imagine, many of the kids in our under-resourced areas are experiencing cumulative losses and cumulative traumas. And so these things are going on in their bodies and minds at the very same time, which can be incredibly taxing, both psychologically and behaviorally and physiologically. And so one of the things we've learned is that the way we go about supporting kids through their PTSD is very different than the way we go about supporting kids through their grief. And so this is one of the examples of one of the treatments that we've been using and disseminating called trauma and grief component therapy, where these are clearly demarcated things so that the second module is just focusing on the trauma processing. The third module is just focusing on the grief processing. One of the other things we've learned is that when kids encounter trauma reminders, these are people, places, or things that remind them of the traumatic event. This is often what leads to symptoms of PTSD. Whereas when kids are confronted with loss reminders, these are people, places, or things that remind them that their person is no longer there physically. That is what often segues into grief. And the reason that's important is because we can empower kids to better understand why they're reacting to certain things in their environment in the way that they are. Sometimes it's just a matter of pointing it out that, you know, that sound is reminding you of the moment when the car accident happened, or that person who looks just like your mom is reminding you that you really miss mom. And by knowing those things and helping to empower kids to understand those connections, we can help them better prepare and feel like they're more enabled to cope with those things when they do occur. Next slide. So I'm going to be wrapping it up now, but for those of you who are interested in some of our trainings that focus on either assessment or intervention, or even for teachers and pediatricians and law enforcement, we have a number of trainings. You're welcome to hover on that link with your camera, and that'll allow you to sign up for our listserv for different trainings. We also have at the bottom there our tagcenter.org website, where we have a virtual learning library that contains webinars on these topics and free resources. One that I just want to highlight briefly is called The Power of Parenting, where we've actually worked closely with individuals with lived experience. These are often mothers who've lost a spouse, and how they've gotten through those experiences to better help their child and support their child through their grief. So this is really a way of empowering parents and caregivers to be able to better help their children while using and utilizing the advice and wisdom of those who have actually been there. So thank you so much for your attention, and I'll stop there.
Thank you, Julie. And I know that we'll be able to talk a lot more about the terms helpful and unhelpful and multidimensional. We're going to move to listen to Robyn's teaching, and Robyn, you're right on time. So we're going to offer you 10 minutes, and then we'll move to Sherman, and then we'll be able to be in discussion. Julie, if you feel comfortable, there's some really great questions in the Q&A box for you if you feel comfortable to respond to them. Okay, Robyn, let's learn.
Thank you so much for the introduction, Leora. Hello, everyone. I feel really honored to be a part of this much needed event and community today. My name is Robyn Douglas. My pronouns are she, her, hers, and I'm currently a clinical psychology doctoral student at Texas A&M University. My work broadly examines both the risk and resiliency experiences of low-income youth and families, Black youth and families, and other families of color. I also partner in research with the Trauma and Grief Institute at the Hackett Center, and my work in that area really examines how oppressive structures can influence the bereavement and grief experiences of racially, ethnically, and financially oppressed communities. So what really brings me to this work is that I consider my work to be really self-relevant. As a Southern Black American woman who was raised in a low-income community, I myself have been exposed to various forms of familial and community loss, and both the sadness and the joy that my community has expressed in such profound and beautiful ways has really inspired my work and continues to do so. So my pursuits are consistently driven by my desire to create culturally informing and affirming community engaged and class conscious resources and care. So I'm really happy to connect with the Institute today and share a bit about some of my recent research in these areas on cultural and class considerations to grief work, and also discuss some additional areas that I believe deserve more attention when we're having these conversations about grief and loss. So when I learned that the theme for this event was really thinking about where are we now with grief treatment and where can we go, I first thought broadly about systemic considerations that we know are contributing to the disparities that we are now seeing in loss for certain communities. So for me, a pivotal first step in being grief sensitive is to really understand what kind of hurdles are helping professionals and communities having to take into consideration in order to support, uplift, and empower our groups. So I think it's really important to take a step back and speak broadly about the increase in mortality rates that we've seen for certain communities more so than others recently. And as we know, there's a lot of research we've seen over the years from public health and epidemiological studies that suggest that Black communities and youth and families are more likely to experience the death of multiple family members than some other communities. And these disparities have been fairly consistent across multiple types of loss, such as homicide, heart disease, cancer, and most recently within the COVID-19 pandemic. And what we know is that these disparities partially result from a lot of structural challenges that can lead to an increased likelihood of Black communities having chronic stressors, such as racism, discrimination, neighborhood disadvantages, and less access to pivotal health resources. And similarly, for Latinx communities, mortality linked to COVID-19 has also been particularly devastating for these communities recently. And to the limited extent that we do have information that's available across countries and ethnic groups, migrant communities seem to be more vulnerable to contagious diseases like COVID-19, as well as deaths related to homicide and occupational injuries and accidents. So what this means is that there are immigrant communities that are also more likely to be exposed to the deaths of their loved ones than communities born within the US. So I think that that is a really important context to think about when we're talking about grief and loss and how there are disproportionate burdens for some communities in their grief experience compared to other communities. And so I really thank you, Julie, for providing that presentation that helps us to contextualize how grief and loss can present amongst bereaving youth and families. That model was the basis for a recent study that I conducted with Julie and other colleagues at the Hackett Center that was focused on disparities in grief symptoms amongst Black, Latinx, and low-income youth and families in disadvantaged neighborhoods. Within that particular study, we interviewed over 400 bereaved families from various cultural backgrounds, and our results essentially found that youth from these three communities in particular were more likely to report experiencing difficult grief symptoms than youth with more social and tangible resources, and that Black and Latinx families in particular were more likely to report losing loved ones to homicide than other racial and cultural identities. So as clinicians, I think we really need to use this information in order to advocate and utilize culturally and class-conscious grief resources. And I want to start by just discussing briefly some community-oriented resources in particular. So identifying community-based organizations such as clinics, hospitals, these can also be schools or other treatment centers, can really have close connections with members of oppressed communities and should really be utilized and partnered with in order to treat communities for their grief symptoms and their loss symptoms. Also, community accepted first responders, which can be teachers. They don't necessarily have to be clinicians. We should be partnering with teachers, with caseworkers, with everyone in these different communities that we know are connected and that they trust so that we can bridge some of these gaps to treatment that we're seeing for these specific groups. And finally, we need to ensure that when working with these populations, we're really considerate of the needs of these communities in our assessment, treatment, and advocacy work. So in order to really move forward as a field, we have to be conscious of the social inequities that are influencing the death, dying, and loss experiences. And we really must do our part in advocating for better health services and resources for these communities, and also identifying factors that have helped these communities to survive and thrive and cope despite all of the barriers that they have faced for generations. So I know I covered a lot of ground there, and I look forward to any questions or comments you all may have about that particular study later, but I'd like to use the rest of my time to talk about another area of grief work that I think deserves a lot more attention right now. And that's considerations for media-induced secondary traumatic stress and grief. So I think we can all really acknowledge that these past few years of the pandemic in particular has increased social media engagement for most of us. And we're already seeing the impact of traumatic media content on the mental health of various groups globally. And as a field of helping professionals, we talk a lot about media-induced secondary traumatic stress, such as having, changes in mood or cognition, being hypervigilant, having trouble sleeping when we're thinking about what we're seeing in the media. But another important factor that I think we talk less about is grief as a reaction to traumatic media content. For instance, as Julie mentioned earlier, circumstance-related grief and distress could be especially one of those experiences. We really have to think consciously about what it means to view or read about the losses of others online, and seeing it every time we open an app or watch the news, hearing detailed accounts of what happened, watching graphic videos that depict the loss of life. These should all be viewed within the context of grief as well, and not just trauma, because we are also having responses to viewing these content on a daily basis. And also, we need to discuss cultural factors in the context of media-related grief. Existential distress could be of particular concern here, because these losses can be very tied to identity. I have here some examples of memorials that were created after the losses of Breonna Taylor, Vanessa Guillen, the Asian victims of the Atlanta spa shooting, the Jewish victims of the Pittsburgh synagogue shooting. I'm also thinking about the loss of George Floyd, the Pulse nightclub shooting, victims of Islamic and anti-Muslim hate. I can go on and on. There's so many examples that we've seen recently in our culture. So we really have to stop and think about, what does it mean to see that someone who practices the religion that you do, or who looks like you, or someone in your family is the same gender or sexual orientation as you, has suffered an injustice? And these are factors that we should really be considering in the context of grief in the future, because actions such as looking for closure, looking for justice for the bereaved, details about what happened to their families of the victims, these are all related to grief reactions as well. And even more so, we've witnessed more instances of racial trauma and disparities in death within our media. So it's really important to think about the specific communities that are being affected when we see these things in the news. And further, it's important to consider community resources following viral traumatic videos that we see. As clinicians, we need to focus on finding ways to help our clients to feel connected when these events take place, and combat the isolation that can take place when we get stuck in these loops of scrolling for more information. So community support groups, virtual spaces like the one we have here today can be particularly helpful here. And finally, it's important to acknowledge that while media can intensify grief reactions for different communities, social media can also be a positive outlet for grief and healing. They can provide the opportunity to keep a connection with the deceased and serve as another outlet for our emotions, similar to what we see in traditional grieving practices. So seeing others who have endured, survived, and emerged from similar significant losses may give others hope. And this can include helping with meaning making, saving written condolences that you can look back on, raising necessary funds for the bereaved, activism, and memory sharing through posted photographs or videos. So with anything, we should take nuance in how we approach media-related grief and bereavement, and also ensure that we're taking care of ourselves as clinicians, because we know that these situations can be difficult for us as well. And so any resources that we can find to help us with media-induced trauma and grief work can be particularly helpful at a time like this. So that's my time for now. I really thank you for inviting me into this space, and I look forward to speaking more later on about the future of grief sensitivity work.
Thank you, Robyn. Thank you, Robyn. As Sherman gets ready to share his introduction for 10 minutes, I just want to recognize that as a former teacher, that we actually, part of what we decided to do was create curricula to help our 11th graders make meaning of when they witness death on their phones, and how to tie in with what Julie was talking about around the importance of meaning making and having a meaning making partner as we are witnessing, absorbing consciously, subconsciously, death and loss around us. So I'm really looking forward to having more of that conversation. And semicolon, we're going to listen into Sherman, who has a bit of a different introduction to his research and his team's research as it comes to grief and new directions in evidence-based practices. So Sherman, welcome, 10 minutes.
Okay, thank you. Thank you, everyone. My name is Sherman Lee, and I'm an associate professor of psychology at Christopher Newport University, which is a small liberal arts university in Virginia. So like Leora said, I'm coming at this at a very unique and different angle. And so I think a good place to start is in the beginning of the pandemic. So in January of 2020, I started to follow the news reports of what was going to be the COVID-19 pandemic. I started to become concerned. At about February, I really believed, though I had many arguments with my friends about the validity of this virus, that there's going to be a lot of crisis. There are going to be a lot of people who are going to be afraid to the point that they probably need some professional support. I was afraid, not at that level, but I figured there's going to be a need to identify individuals, because this particular event was creating a new kind of fear. It's not, some general thing. It was very specific, very unknown. And so in the time between February and March, before the World Health Organization declared COVID a pandemic, I started to study people who had significant fears related to the coronavirus. And I'm not from a big university. I have no big grant. I'm just a small liberal arts professor. But I figured I have skill set in measurement, and I wanted to help by developing screening tools. So the first screening tool I developed based on studying people who had clinically significant fear to the point that they couldn't work, they couldn't take care of themselves, right? So we talk about the spectrum of mental health. My concern is a very small pocket of people who are in a crisis situation and will benefit from some kind of professional support. So again, as we talk about grief, widely spoken, I'm talking about a little pocket, small pocket of people. So anyhow, collected the information, developed the scale, and got it published in Death Studies, and started to get other people, because that was how I can get globally visible and work with other people is through the validation of that work. And so from getting a 5-item screener that was specific to coronavirus anxiety, I had to branch out and, of course, replicate our work. That's a big problem in psychology, is replication. So I had to make sure I did replications, but I was also at the same time connecting with researchers across the globe who are also interested. And that pushed me also into developing a website, which I'll show you at the end. But as you'll see, it's very bare bones because I have no technical skills other than what I can learn. And I just put a little Google site and realized people wanted copies of the paper. They wanted PDF copies of the scale. They wanted translations of those scales. And so I started that process of not just bringing the science into the measurement, but also providing a useful hub for people to gather resources. It's still going today. It's a daily thing for me to update. And so from that research, we're at the point now where the anxiety scale is used clinically for general research and, of course, in training, similar to this. Now, I talked about anxiety, but I followed this same format with my mentor and colleague, Dr. Robert Niemeyer, in November. because at that point, we were so concentrated on anxiety that I didn't think, I thought someone in the grief world was going to pick up and do mental health screeners. There were some papers proposing some, but by November, we didn't see anything published. So we used the same methodology, the same approach, again, with the focus of identifying individuals who are not functioning well and who may benefit from some kind of professional intervention. Next slide, please. So this is just a snapshot of one of the pandemic grief scale that we looked at. So we looked at the DSM-5 symptoms. We thought about symptoms that people were reporting anecdotally about their grief experiences during the pandemic. And so through the distillation of all that, through factor analysis, we found 5 of the items that were really able to identify people who were at that level of crisis. And so this is, again, it's not a comprehensive tool. It wasn't designed to be diagnosing anyone. It was simply to find some kind of line to be an entry point for people to validate their specific experience in the pandemic. Next slide, please. And so there's just some resources here. The Coronavirus Anxiety Project is the one I was talking about before. You can get PDF copies of the scale and make connection with other scholars there. Pandemic grief is focused on pandemic related loss. I also posted the National COVID-19 Day website, which is a big event, great place for resources for people who are supporting or need some support during this pandemic. I also posted Portland Institute for Loss and Transition, where you can get training from Dr. Robert Niemeyer's work. So I'll stop there and let you guys take over from there. Thank you.
Thank you. Thank you. Okay, big breaths. I'm going to do a shoulder roll. Welcome everyone, including folks on the panel too as well, because now we just heard where we are and each person's take on where we need to go. And I'm really excited to center us in conversation as though you were here with me in Berkeley in my living room. And I know, as someone who is not a clinician, but is clinician adjacent in the mental health field, that one of the biggest conversations is how we know what we know and how do we acknowledge what we don't know, and how do we sit in the both and. And I'd really like to center the question on actually, what do we not know? What are you seeing that we are either misreading as something because we feel like we need to know? We need to, as you said, Sherman, there's a propensity to want to diagnose, and actually your scale is not to diagnose, but I loved the term you used, validate and then resource people who need intervention. But how do we actually talk about what are we missing? Are we missing grief for anxiety, or trauma for grief, or depression and sadness, or different ways of expressing? And how do we sit with that not knowing? So I'd love to hear from the three of you. What are you seeing from your eagle eye and in your practice of what do we not know? Anyone?
So I'll jump in. And can you hear me okay at this point?
Yeah,
okay.
Yeah. You had a little. You were in my club earlier with the audio chop, but you're good now.
Okay. Well, I apologize for the choppiness. I think one of the things that we're still really trying to better understand is, I'm hesitant to even use this term, but in thinking about, good grief. So what does that helpful grief look like in children? And so much of the attention has been focusing on the pathology, right? So with prolonged grief disorder coming out in the DSM-5, we have worked on a measure to screen kids similar to Sherman who may be experiencing high levels of distress and who need a higher level of support. But I think what we really need is a way of better evaluating what are the strengths that kids have in the aftermath of a death. What does that look like? How can we harness that? We're learning a little bit about that based on some of the work that we've been doing, but I think also better understanding what are the ways in which parents and caregivers can go about supporting their kids after a death. And again, I'll go back to one of the studies that one of my former graduate students conducted was really looking at conversations between the surviving caregiver and the child. And she was very focused on the content. So what was the caregiver actually saying to the child? Interestingly, after the study, when we analyzed the data, it really was not about what the caregiver was saying. It was about what the caregiver was doing. So being fully present, making good eye contact, giving the child a hug, literally appearing as though I am ready and willing to hear what you have to say. And it was not so much about what they were actually saying, but it was that sort of presence of, I know that, I want to hear what you have to say. So that's something that we often tell caregivers now, because so often the focus is on, I just don't know exactly how to talk about it. I don't know exactly what to say. I want to have that, good conversation that help. And what we say time and time again is that many of the things that you're already doing are actually helping your child, including just being there and listening and bearing witness. So anyway, that's my 2 cents.
Yeah, thank you, Julie. I want to underscore that term bearing witness, and really highlight that for so many of us, myself included in the education pipeline, that for so many of us in the field, we are so trained on the implementation of the thing rather than holding space for the relationship and conversation between the screener, young person, client, and provider. And so I'm really, thank you, Maria, for saying the providing safe space, holding space, and how that's such a skill in where we need to go in the mental health workforce. And so much of that skill, I think, relates to one of the questions that came up. And I just want to name it, and we can go there or we can go back to where we started, but the interplay between our own as providers grief experience and how we then provide to others. And I'm curious also if there might be room for us to talk about grief bias in our practice as an understood dynamic in our ability to witness. But so that's that, or also, so there's there, or also going into what do we not know? Anyway, Sherman or Robyn, what comes up for you? Sherman, you got to unmute.
Oh, I'm sorry. Do you mind if I jump in, Robyn?
Please go.
Okay. I just want to be considerate. We had an order. So when we talk about things we don't know, it brings me to think about the very specific aspects of loss during the pandemic. And we studied it and we just scratched the surface, but there are very unique aspects of loss that we found, such as having a lot of anger towards the medical staff of a loved one who died in a facility. That's a very specific, unique aspect that you have to look at. And we saw that it was tied to, of course, a lot of distress, a lot of anger. What we don't know is how that may manifest later because of its unique a manifestation here. Similarly, I recall having a talk with a bunch of doctors who were retired, and it was an interesting talk. It was about grief, but what I found when we were talking is that there was a lot of guilt underneath, where I think people were spreading the virus during the funerals, because they were talking about funerals every 3 weeks, and a lot of them were elderly. And then they were kind of almost identifying where they got it. So I see a lot of those aspects that seem to be pretty unique to these conditions. And so I think what we don't know that I'd like to see more of is how those unique circumstances affect people's mental health and how we approach those issues.
Sherman, what you just brought up for me connects to the term that we often use around complex or complicated trauma, when the system that you have expected to support you actually is inducing harm. And I'm wondering if there's a new, I know that we're not the New Directions panel, I know, but in light of our theme of where we need to go, I wonder if there's an opportunity for us to do some study and some inquiry around compounded or complicated grief at the systems level. And I don't have language for that, but maybe we can help that. But I appreciate that narrowing in on anger as also being deeply central, because we know that anger, from Gabor Mate's work, is a symptom of feeling violated, both individually and collectively. Robyn, you were going to speak.
Yeah, Leora, I think you touched on something really important earlier, which is grief bias that we may see from clinicians, especially in the context of what we've experienced over the last couple of years, where a lot of us are dealing with various forms of losses. And so I think it's also just really important to have spaces for clinicians or community first responders or people who are working with these communities to have space to process their own individual and communal relationships with their grief. So I think that's an important first step. But just speaking more broadly about grief bias, I just also want to acknowledge that while grief and mourning are all universal experiences, the ways in which individual cultural identities are responding to grief can include a lot of different factors, like religion, personal beliefs, community traditions, right? And so it's really the responsibility of us as providers to learn how the cultural backgrounds of our clients are influencing their beliefs about death and mourning, and coming at it from an angle of cultural humility instead of, judgment, which I know we're not trying to do. We're not trying to be judgmental, but we want to approach these things with integrity and an acknowledgement that the ways that we experience grief are not always going to necessarily be the ways that other cultures and communities experience those situations.
Yeah, I think that's really important. And the call in for those of us in listening right now is an invitation for us to really sit with, exactly as you just said, how did we come up in our own personal experiences feeling validated in the way that we experience grief, and how might that influence the way that we validate others in our professional and personal practice? Yeah, well, that speaks to the workforce development question. So from the three of your lenses, if we think about the pipeline of the mental health workforce, and we define the mental health workforce in our network, both specifically and broadly at the same time, folks who are clinically validated, so social workers, therapists, psychologists, and peer supporters, and also folks who often don't get the validation of being part of the mental health workforce, community advocates, promotoras, et cetera. If we think about where we are right now in 2020, with the training and professional development and all of the pre-service work or in-service work that we want to provide to folks, what are your recommendations with where we need to go in our support of the mental health workforce?
So Leora, I can jump in briefly.
Please, I was hoping you would, yeah.
Okay. So I think, what we hear time and time again from, social workers and psychologists is that they did not necessarily receive any formal training in graduate school related to grief in particular, or, how to be with grief, or to how to think about grief, or even for those individuals who need a higher level of intervention, what does that look like and how should they intervene? And so one of the things that we've really been trying to do through our Trauma and Grief Center, and Leora and your team have been so supportive of this, are what we call learning collaboratives, where we bring together 40 to 60 clinicians at any given point in time. These can be school-based or community-based clinicians or school counselors. And we train them in one of the evidence-based interventions that we know can directly address this intense distress that some kids might feel after a death. And then once we train them in that, it's usually a 2-day training, we then send them to their respective settings to do the work while providing ongoing supervision. And I have to say, those ongoing supervision calls, when we look carefully at the data to see what helps the clinicians to feel comfortable and confident in implementing the intervention, what helps them to feel like this is something that they would want to sustain, it really is that ongoing consultation. So what we find is that when there's a one and done training, Yes, the information is helpful, but it doesn't really help to make the intervention stick and to help clinicians feel confident in continuing that practice. So that's something that we're trying to do, recognizing that, you know, we really do need to empower communities to be able to address the needs of grieving youth in the most appropriate way. That includes making sure we're not pathologizing those kids that are grieving in a healthy way. And also, you know, ensuring that we're identifying those kids that really are stuck and need our help.
Yeah, thank you. Thank you. So you're elevating the necessity of training being acute and also ongoing, and providing individualized consultation for providers. And I witnessed one of those calls where providers are bringing up their own grapplings of what am I seeing? Am I not seeing? Am I seeing the right thing? Are you seeing what I'm seeing? And being able to be in deeper understanding around grief. Thank you.
Yes.
What about you both, Robyn and Sherman? Where do we need to go?
Just briefly, just touching on what Julie was suggesting earlier, I myself didn't receive training in grief work until I started my master's program and my clinical work with the Trauma and Grief Center. And so I also think that speaks to this larger need for us to increase accessibility for underserved groups to receive more information about how to process grief and loss. And also we need, just as a culture, I think, to really destigmatize these conversations around loss and grief in general, so that earlier on in our identity, we know that we can talk about these experiences with grief and that we can normalize them. So as a culture, we're able to like make it more accessible for people to receive the support and the training that they need.
So I think I can add two things to Robyn and Julie. One, I liked how Julie was talking about what's effective, and it's interesting. It wasn't necessarily the right words, but it was being present. You know, very old school Rogerian pieces, and we see that. I mean, just being a human being, getting in touch with being a human, I think is one of the big areas, because I think that was the disconnect that we found in our data with people dealing with these issues in the medical profession, medical providers, is that, again, they feel disconnected, not heard, disempowered. And so they're already going through a lot of stresses. And again, from the doctor and the medical point of view, they are also dealing with their stressors. And so I think it's good to highlight very basic humanity. I think the second thing that Robyn brought up, and I'm highlighted this when I talk to colleagues like from Pakistan or from Nepal, from areas, is really think about the hierarchy of needs. Really, what is it that within their loss they're going to need outside of psychotherapy and counseling, supportive things? Because in some of these family structures, like some of the women in Pakistan that I was hearing about, they have to switch and be different kind of resource allocators. So their needs are going to be a little different than, I think, someone from another place. So I think we should think about what is it that they're going to need for where they stand. So those are the two pieces.
Thanks, Sharon. I think what you're naming is part of also Robyn's research around how do our socialized and social identities impact and influence the way that we are able to resource ourselves, that we're expected to resource others, and that we're validated and invalidated across intersectional identity lines. I'm seeing that there's connection there, and I'm also noting that in the Q&A box, there's a lot of desire to really center both conversations around white grief, folks in white bodies who frequently are not held accountable and held in holding around what grief looks like in the white body and how that might translate and come out in other forms. Those are a little bit of my zhuzhing on some of the questions or intersections of both whiteness and class. And then another invitation for us to center Indigenous culture and culturally defined practices. And so I just want to name for folks on the line, both in the New Direction session coming up and also deeply in the lived experience culture and grief session 3 that Teresa will be facilitating. That will be a really lovely place for those conversations to come alive. I want to ask one last, maybe two last questions before we close. There is a specific question around grief related to violent loss, both either death by suicide, death by accident, death by gun, and what was not named were also death by system involved. So in terms of law enforcement and police. And I'm curious if there might be some teachings around what we know and what we need to know related to violence involved grief.
So I can jump in, and then I'm sure Robyn and Sherman have things to say too. You know, what we've learned, especially with children and adolescents who have experienced very traumatic types of losses, like due to violence or suicide, is that, you know, again, they often become very preoccupied, as they normally should, with the circumstances of the death. So things like, you know, worrying about, I wish I could have intervened. I wish I could have saved them. What could I have done? We see this in kids as young as age 7, you know, thinking to themselves, there must have been something I could have done to protect this person. You know, and then there's also issues of social justice and, you know, becoming enraged when these things happen and not knowing where to direct that anger, feeling unempowered or disempowered to be able to do anything. And so I would say that often this is why this is the reason why we typically tend to start with the traumatic stress responses, the circumstance related to stress, getting past that, getting through those experiences and processing those experiences before we move directly into the grief. Because often what happens, especially with kids who actually develop PTSD, is that any time their person's name is mentioned, they're flooded with those terrifying or anger-inducing thoughts and feelings and really can't go there. They're too focused on the circumstances. So if we can get through that piece first and process that first, often that's required before we're able to actually move into more of the grief processing.
Thanks, Julie.
I agree. And I think it comes back even to what Sherman was mentioning earlier about the hierarchy of needs, right, for different communities. When we're working with youth who have lost loved ones to violent deaths, it's important to really think about feelings of fear or concerns about safety that they may be having after those losses, you know, and that can really be dependent on the circumstances of the loss, whether it was to community violence, if they live in communities in which violence is sort of normalized within their environment. It's also important to think about what's happening in their bodies on a daily basis, what they fear they may come across, or what may happen to their remaining family members. And also just in general, thinking about how their responses to those losses might look differently in the context of violent loss compared to losing someone to an illness or to another type of loss. Thinking contextually about how losing someone to a violent death can have effects on their mental health outside of just grief is going to be really relevant there.
Mm-hmm. Thank you.
So I'd like to piggyback on Robyn. I think it's probably more appropriate to find out, not more, but I think it's appropriate to see how the individual sees and perceives that event. Sometimes there's some religious taboos over how that happened and their role in it. Again, wondering if they had any kind of role in that aspect. So there may be something about their belief system that we need to be aware about. So I think it's important to kind of see how they're seeing it from their perspective. Again, I'm trying to get beyond, I'm getting a little more global, because as I learn about these different cultures and interact with these different researchers, their concerns aren't necessarily my concerns. And so it's learn to kind of step back and try to learn what is their interest.
I'm appreciating that deeply, Sherman and Robyn and Julie, especially because what it helps us remember is that in all of the ways that our own individual, interpersonal, interconnected, and ecosystem-based belief systems have so much weight. Sometimes it's helpful for us to think about the individual client or young person. Sometimes it's necessary for us to get more systemic in our analysis and in our inquiry And the three of you in the work that you have elevated holds both the macro and the micro. And I just want to acknowledge that there's some comments in the chat box, particularly of folks who said, I was trained in an evidence-based practice, and then I experienced personal loss, and my understanding of my evidence-based practice radically shifted. And that so relates to our colleague David Kessler, who himself, as the loss of his son, had a completely different understanding of all of the teachings that he had done henceforth. And so I just want to close this session really honoring that the evidence-based and culturally defined practices, when we sit with grief sensitivity, what we're hearing from the three of you is the relationship between the personal and the professional, and the individual and the collective. I'm going to offer just a quick rapid fire round a la Brene Brown of if you could say or ask or offer anything for the almost 700 folks in the room, what would you like to offer them? And then we'll close looking ahead. Who'd like to go first?
That's such a hard question, Leora.
I know, I'm sorry.
No, I would say for those who are helping to support grieving children, the take-home message is to just simply be present and give them that safe space where they can talk with you and know that it doesn't have to be a one and done conversation, that these conversations are going to continue over the course of their lives, and knowing that you're there to listen is the most important thing that you can do.
Yes. Thank you.
I'll just, oh, sorry, Robyn. Go, Robyn. Go ahead.
Just real quick, I just want to say to everyone who's listening that your experiences with loss and grief are valid, no matter what community you come from or what brought you to this space. Know that you offer really valuable insight into ongoing conversations that we're having surrounding grief work. And so continue to take care of yourselves today, and feel free to reach out to me, I'm sure to Julie and Sherman as well, or Leora, if you have any additional questions about things we talked about.
Thanks, Robyn.
And so I would like to add, I think being who you are at the human level is the best place to start. I don't think the intellectual place is the place to start. I think it's the place to go to. And I think if we meet people where they are, if we know who we are, we're all good. I'm out.
All right, well, that was the evidence-based and culturally defined practice session, saying being who you are and humanizing and listening and holding space is the work. So there we have it. I'm going to really invite you right now as listeners to, and actually I just said all panelists and attendees, don't listen to what I just put in the chat box. If you can actually just write to everyone, and you're already doing it, a kudos or a descriptive praise of something that you heard in your takeaway. I'm going to invite Heather to bring up the slides so we can do a transition. And what I also want to offer to folks who are listening is that there were lots of questions around anticipatory grief, around disenfranchised grief, and many other aspects of this work in the grief recovery method. On our event page are all of the recordings of our workshops from GSVLI 2020, including from Pauline Boss, including from the recovery method, including from Dr. Ken Doka. So please go back to those recordings to do deeper learning so that this conversation can fit in the nest of that work. Incredible, incredible gratitude. It's very hard in 10 minutes and then in even less time to share all of what you are holding with urgency into the universe. So we're grateful. I'm going, and please, I hope you're reading the chat box and reading the chat box. I am going to invite the panelists, Robyn, Julie, and Sherman, and myself. We're going to be answering some of the questions that may needed more attention that we weren't able to get to because I was focused here in the intermission. I want to offer, we have 10 minutes now. Invitation is to stretch, eat, move around 10 minutes. Our next session is on new directions, which I am incredibly excited about. We have Erin, Erica, Noni, and Lisa to share about their learnings with where we need to go in the field in grief sensitivity. That's coming up in 10 minutes after the hour. And then the third session is with Monique Minahan, Roshni Kavate, and Monique Castro on lived experience, culture, and grief, which I think now knowing all of the comments and the questions and answers will be such a profound session for us. And then we'll come back with Megan Devine at 1:55 PT, Pacific time, so do the calculations in your own zone. And then we'll close with some somatic work. So the same webinar link all day, come in and out, join us, ask for help, we'll get you what you need. Again, Julie, Robyn, and Sherman, thank you so much for starting us off so richly. Thank you for landing on the most powerful element is to humanize, hold space, deeply listen, and validate. And we are going to have intermission now, which means that you get to go off camera and we get to pull up the next session speakers and do some tech work. So for those of you who are listening in, you might hear us kind of behind the curtain, figure out audio, et cetera, et cetera. We are going to officially start at 10 minutes after the hour. Thank you again.